I'm Tom Luscher, and today we will again talk about inflammation. It is more than 100 years ago since Rudolf Virchow coined the term atherosclerosis is a chronic inflammation induced by cholesterol. And indeed, when we look at this slide that you see here, the inflammasome is activated by cholesterol crystals, then activates interleukins, and what we measure essentially in our clinical practice is not this pathway, but rather CRP, because it's easy to measure and cheap. Now, we learned that this is particularly important in acute coronary syndromes, and we have shown, as others did, that if you have an acute coronary syndrome, you have huge increases in CRP, but also serum amyloid A and other acute phase proteins, including, of course, the interleukins that we regularly do not measure. So inflammation is crucial in plaque rupture, plaque erosion, and therefore for the triggering of acute coronary syndromes. The question is now, with evidence-based therapy as recommended by the ESC guidelines and other guidelines, can we reduce this chronic inflammation and prevent further events? And here we recently published an interesting paper from our large prospective cohort, where we show, as you see on the next slide, that the odds of having additional events markedly depends whether the current treatment is able to reduce inflammation or not. And on the top you see those with persistent inflammatory risk, and you see that their odds ratio is very unfavorable. They have additional MACE events. Those who are able to suppress their inflammation due to the current treatment do not. So this is the population that we have to select now and identify at the time of the acute coronary syndrome to allow them to receive anti-inflammatory therapy. So this is the next step in our adventure to understand and treat inflammation. Thank you for your attention.